Okay. So, good evening, everyone. This is Dr. Ruta Kulkarni, President Asami India. I welcome you all for this webinar. This webinar actually is the third one in the series of Ask the Masters. And this webinar is hosted by the state of Karnataka. I welcome all the masters, Dr. Kovoor and Dr. Harshad Shah. And the speakers, Dr. SHESHGIRI, Dr. KUKREJA, Dr. ARADHANA RATHOD, and Dr. SATISH NESARI. I welcome all of you. I also welcome all the seniors who have joined in. So before starting this meeting, I would like to make an important announcement. Tomorrow, that is on Monday at 9 p.m. in the evening, we are going to have a GBM, an extraordinary GBM tomorrow. So I request all of you to please join. It's going to be an important GBM. It's regarding changes, amendments in the Constitution of Assam, India. So I request all of you to please join. Last time we had to postpone the meeting because of lack of quorum. So I request again and again all of you to join tomorrow's meeting. So without wasting any time now, we will start this webinar. I hand over the meeting to Dr. Manish Prasad. Over to you, Manish.
Thank you very much, ma'am, indeed, for this introduction and welcome. And good evening to everyone, all the seniors and my friends. As ma'am has already introduced, it's the time for the state of Karnataka to conduct this Ask the Master series, the academic initiative by Asami India, where we are discussing, we will be having case-based discussions. We have senior Asami India experts, Dr. Harshad Shah sir and Dr. Kovoor sir. We have a stellar group of speakers. We have Dr. Satish Nesari sir today, who's an assistant professor in Belgaum. Then we have Dr. SHESHGIRI. He's an associate professor at JSS Medical College, Mysore, followed by Dr. KARAN KUKREJA, who's a consultant orthopedician at the Manipal Hospital, Bangalore, and finally the state representative, Dr. ARADHANA. In fact, she's the one who has taken the maximum initiative to get this whole thing stitched up properly. She's an assistant professor at the Bangalore Medical College. So I would, without any further ado, I would invite Dr. Satish Nesari sir to get along with this topic, that is valgus deformity of ankle secondary to fibula osteomyelitis with bone loss managed by Ilizarov ring fixator. Sir is an accomplished academician with lots of degrees and fellowships to his credit. So over to you, Dr. Satish sir. Thank you.
Thank you. Thank you, Dr. Manish. So I ask excuse for the change in the title. It is congenital pseudoarthrosis of fibula with valgus deformity of the ankle joint, which was managed by Ilizarov. This is one of my interesting cases in my lifetime. So this a 14-year-old boy presented to me with ankle deformity and pain in the left ankle after a long distance walk. So patient gives and parents gives history of trauma to the left leg 2 years back, and was associated with the pain, fever, and swelling. And he had a second incident of trauma to the same leg 8 months back, following which the previous symptoms aggravated, and also the parents noticed ankle deformity, which appeared at the time of second trauma incident. So this is the picture showing the ankle deformity of the left ankle, and this is the walking video of the patient where the deformity is present while walking. So I took an X-ray of the left ankle, and I noticed that the fibula is lying on the superior and posteriorly, and a little bit inclined also. When I drew a tibiotalar angle, it was less than 90 degrees. And also I noticed that the height of the lateral epiphysis of the tibia is decreased and it is compressed. So I managed to take a comparative X-ray of both the legs with the fibula, with the patella facing the ceiling. So I noticed that the affected, that is the left lateral malleolus, was lying posteromedially, superiorly, and inclined medially. And also we can see that the fibula has become thin and with the loss of substance of the lower third of fibula. So I got an MRI done for this patient. So MRI showed there is subluxation of the tibiotalar joint and increased medial joint space of the ankle. And also the fibula showed marrow edema, query, osteomyelitis of the fibula. So I kept in mind the two differential diagnoses. First one is a congenital pseudarthrosis of fibula type 3 and osteomyelitis of fibula. I could rule out osteomyelitis of fibula because there is no history of open injury or no history of discharging sinus. And so my final diagnosis was the congenital pseudarthrosis of fibula. So there are 4 types of congenital pseudarthrosis of the fibula, isolated congenital pseudarthrosis of the fibula. In type 1, there is just a bending of the fibula. Type 2, pseudarthrosis of the fibula with stable ankle. And type 3, pseudarthrosis of the fibula with ankle deformity, that is valgus deformity of the ankle joint. In type 4, it is associated with the features of pseudarthrosis of the tibia also. So in type 3, because of the migration of the lateral malleolus posteriorly and superiorly, the lateral support of the talus is lost, and this will lead to increased pressure over the lateral epiphysis of the distal tibial epiphysis, leading to compression of the epiphysis of the lateral tibia, lower tibia, and this leading to the subluxation of the talus and valgus deformity. The treatment suggested in textbook until skeletal maturity in type 1 and type 2, the aim is to prevent ankle deformity by giving ankle foot orthosis. And also Langeskiiold suggested tibiofibular synostosis in children to prevent ankle deformity. At maturity, the textbook suggests supramalleolar osteotomy to correct ankle valgus. But when the ankle is developed in children before maturity, so there is no treatment mentioned, but in some of the literature search, they have suggested medial tibial epiphysis when there are no symptoms. But this patient had symptoms. So my plan went accordingly like this. So since there is no support to the talus on the lateral side, I thought of bringing back the fibula to its original position by giving a push superiorly, posteriorly, so that a lateral malleolus will come to lie abutting the talus, supporting the talus. So my process started with initial lateral distraction of about 5 mm, just to pull the fibula out and give some space for the movement of the fibula. So next, I corrected the inclination of the lateral malleolus, and then I translated the fibula anteriorly and laterally, and then translated it inferiorly. So the fibula transportation managed with these 4 steps. So this is how I applied the Ilizarov. There were 2 tibial frames and one half calcaneum frame. I gave slight distraction to the ankle joint, and then I fixed the fibula with the 4 small half pins, which was held with rancho cubes of 4-hole rancho cubes. This rancho cube is attached to the translation assembly, which was fixed to the lower end of tibia and the calcaneum half ring. With every step, I had to change the direction of the push, that is the motor rods, and bring the fibula into the normal position. So this is how the immediate post-operative X-ray looked like. So always I used to compare with the, I took the X-ray and compared with the opposite fibula, opposite leg. So here in X-ray you can make out 4 Shah spin, and the fibula is lying a little bit higher than the normal level of the normal fibular level. So I started the translation of the lateral malleolus anterolaterally, inferiorly by Ilizarov. Here, what difficulty I encountered is every time when I took the X-ray, fibula tip and fibula was not clearly seen. So I had to correlate clinically. So my clinic, I had to depend more on clinically, because on X-ray, many of the time the connecting rods or the motor rods or the rings, they used to overlap, and I was not able to see the fibula properly. So I had to depend upon the clinical methods of evaluation. So it took about 3 months. So the patient was there for 3 months in the fixator. And at the end of 3 months, I could bring the fibula to the normal level. And here you can see with great difficulty, I could manage with various wheels to take to see the tip of the lateral malleolus, which has been restored to the normal level. So at the time of frame removal, I inserted 2 CC screws, 4 mm CC screws, so that is syndesmotic screws, fixing the tibia and fibula, just to prevent the lateral malleolus going back to its preoperative position. So always the opposite X-ray, opposite leg X-ray helps us to quantify, to make out how much degree of correction we have obtained. Here in this X-ray, we have compared both the tibiotalar angle of both the legs, both the ankles. And on the left side, we can see the fibula is well aligned. So I have compared the preoperative tibiotalar angle with the postoperative tibiotalar angle. Preoperative, it was 73° valgus of the ankle joint, and postoperatively, it was near normal. It is 85°. And on the right side, you can make out the preoperative ankle valgus, and postoperatively, the ankle has been corrected to the neutral. So now my next plan is to either give an AFO for this patient and wait until maturity. And after maturity, if ankle deformity develops, I can go ahead and do the supramalleolar osteotomy. And if not, I can also plan a tibiofibular synostosis in this patient. So I withheld this fibular synostosis because MRI showed signs of osteomyelitis. So once I am confirmed that there is no osteomyelitis, I can always go ahead with a tibiofibular synostosis. So this is a unique case because I had to the frame which I mounted is of I felt it is challenging, and that's why it is one of my challenging and interesting case. Thank you, sir.
Yes, very good, NESARI.
Thank you, sir.
Thank you, sir. Thank you for this nice presentation. May I now request our experts to kindly give their views and comments. Dr. Harshad, sir.
But I'm not able to see anything. I saw the last slide. I didn't see, of course. NESARI, that was a really good one. I don't know. Can you all see me?
Yeah, yes, we can see you, sir. But yes, sir, we can see.
I have one question to you, NESARI. This is a beautiful work that you have done, and a lot of thinking and wonderful things that Ilizarov can do. Yes. My congratulations to you.
Thanks,
Did the tendoachelis come in the way for you? Because you said the fibula has gone behind the medial malleus that side, isn't it?
It was not too much posteriorly displaced, sir. So tendo Achilles.
It was shifted posterior and then behind the tibia, isn't it? So it is
not completely behind tibia, sir. It was far away from the lateral tendo Achilles.
It is on the lateral.
Lateral. Yes. Lateral to the tendon. Yes, sir.
Okay. That's
the main thing is that when you have given the distraction, there was distraction, osteogenesis took place, because I am seeing that lot of bone is formed over the fibula. So that was the excellent thing, because we never expected in the pseudoarthrosis tibia that there will be osteogenesis. But when you have given the distraction, excellent osteogenesis took place, and virtually the fibula is united. I was thinking how to the fibula will unite, but it's a nice presentation, and the fibula is united nicely. In future, you may need any correction or you may not need any correction. If any correction will be done, so the supramalleolar osteotomy can be done.
Yes, sir.
Yes, Satish, good work you've done. Now, 2 questions. How did the LDTA, that is lateral distal tibial angle, come back to normal without osteotomy of the tibia? That is something that.
Because probably when I
small valgus, but how did it come back to normal?
Yes, sir. That's why
you can see is angulated.
Yeah. Maybe in preoperative X-ray, there was a compression of the lateral tibial epiphysis, sir.
Probably,
and when I distracted it, probably it has grown back and it has pushed the lateral part of the talus, and also the fibula, which was not supporting earlier. When I transported it distally, probably it has pushed the fibula, that is talus, to the normal, near normal position.
Yeah, probably that I agree. And one more suggestion, I think you should have done the tibiofibular synostosis at the time of frame removal.
Yes, sir. Because preoperative MRI showed osteomyelitis, so I deferred doing that. So anytime.
Osteomyelitis was only a differential.
I think you can freshen it up and put cancerous grafts there.
Yeah, anytime I can do it, sir.
If you had done a tibiofibular synostosis, because the chances of recurrence would be much less.
Yes, that, only the thing was preoperative. Patient gives history of fever and all those things. So that's why I thought I should not take the chance, and I can anytime do a tibiofibular Langen's-Kovoor procedure at any time, sir.
Yeah.
No, now, as of now, the screws are there to hold it.
Yes, yes.
So the screws you will keep for how long?
Maybe, sir, madam, I will just keep an eye on a patient, and if he develops any pain or anything like that, probably I will remove the screws and do a tibiofibular synostosis.
Yes, I think it's a good idea to fuse it, because once the patient starts weight bearing, the screws just might break.
Always the syndesmotic screws, they break, madam. Whenever
I think it's better that you start, before the screw implant is going to fail at some point in time.
Yes.
I think it's before you do, don't remove the implant. I think you better go ahead with the tibiofibular synostosis also. Safer that way.
Yes, sir. Already I have mentioned my plan, next plan.
The ideal time to remove the screw is minimum 6 months to 1 year.
Yes.
Otherwise, the whole thing will be spoiled. That is the problem.
Yes, sir.
The main thing is in some of the cases of the neurogenic where there is a valgus deformity, we transport the fibula downward. So it pushes the lateral and the medial side. And that is a good thing has been done. I do not think there will be recurrence of the deformity.
I have one question to everyone. The distal tibial epiphysis was angulated before this procedure, and the height of the epiphyseal plate was more medially than laterally.
Yes.
Now, after the fibula has been corrected, the medial side of the distal tibial epiphysis is quite thick. The lateral side is thinned out. And the gap between the talus and ankle joint is increased. If NESARI can show that last few X-rays of the results, probably you will understand what I'm trying to tell. Is the need for an osteotomy there for that? Otherwise, it will go into valgus. Growth will be more on the medial side. Again, it will go into valgus. Again, the fibula will go out. There will be a big problem.
Yes, sir. Possibility is there. That's why if you see here, sir, one of my syndesmotic screw I have put it onto the medial growth plate in order to do medial tibial epiphysiodosis. I don't know how much it will work, but while doing it,
Satish,
yes, sir.
it is unintentional.
No, sir.
No, that is unintentional.
No,
But
sir.
here the problem, the issues are how much is the growth you are expecting from the distal tibial physis in a 14-year-old boy?
Yes.
Not
Not
very
much,
much.
sir. Not much.
Not very much.
Yes.
So you have done a wonderful out of the box thinking about the fibular transport and all. We'll
Yes.
see how long it is going to work.
Yes.
I
Sir.
think I personally would like to block the medial side of the tibial
Yes.
epiphysis.
Yes, sir. Yes. I agree to it, sir.
So that is in future at least it won't become bad.
Yes, sir. Yes.
You can do
Yes.
all other tricks. Plus
Yes.
along with that the last stage or even the first stage itself, I will
Medial
block the
epiphysiodosis.
medial epiphysiodosis.
Yes.
Just
Yes.
Just
drill
put
it
a
out.
screw from the through the middle
No,
malleus.
14 years, no, just
Yes,
drill
yes.
it out.
Yes.
Actually,
So
the
screws-
growth in the children is up to 15 years, boys. So there is a 1 year is left there now.
But
That is
Satish,
That is why I would say that is why you can wait for a year or a year and a half.
Yeah.
Yes.
And afterwards, you remove the screw, do a
Do
distal
it.
syndesmosis, and do a
Yes.
supramallear corrective osteotomy, whatever you require.
Yes, sir.
Harshad,
Yes.
Still
when
go
do you
for
need a
more
supramallear
valgus.
corrective
Harshad,
There
osteotomy
is no
now?
fibula at the top.
Arshad, the rest of the 1 year growth is not going to be a balanced growth. It's an unbalanced growth.
I know. That is why
So
you'll
it's
get a
better to block
deformity.
it. We don't
So
want
when
any
you get a
deformity to
deformity
come up.
later, you can correct it. You give a protected weight bearing as of now. Anyway, you're going to wait 6 months to 1 year for the child to do, for the boy to
Yeah.
come. So that way,
At least
okay.
1 year you have to wait.
Sir, I have a question for the panel, sir.
Yes.
What would be the result if I do a primary supramalleolar osteotomy at the beginning only? Because there is no support to the lateral support is lost because of fibula had migrated up. If you do a supramalleolar osteotomy as a primary procedure, how it is going to is
Yeah,
it going
you
to survive?
I tell you,
do it.
if
Without
you
fibula
Even
support.
if you-
about 5 degrees of
Yeah.
barrel. So
Okay,
long
sir.
as the medial malleolus is intact, it is
Uh-huh.
not going to create any trouble.
Yes.
but
Yes,
at
so-
least you need the
Ideally,
length of the
virus.
fibula. That is most important. That
Yeah.
you have gained in this surgery.
Yes,
That
since
is
you've
most
done that, but I would still strongly insist that you do the Langenskoil procedure also.
Yes.
Yeah.
Yes, sir.
Because it's going to fail at some point of time.
Yes, sir. Yes.
All right. One last question. Suppose we did not have Ilizarov. How will you treat this conventionally? Anybody has seen such patients where they can treat conventionally? I think
Yeah.
Karen
you
might
can-
have got some experience.
You cannot do. Because
You
can
by
do-
any
can do a
procedure,
No.
Medial
Something they will
epiphysis.
try. Conventional treatment without Ilizarov. If
Yeah,
the
you
fibula is angulated and displaced posteriorly, like in this case, what would
Main-
they have generally done?
main
Just
do
problem
a
is,
supramalleolar osteotomy.
yeah, but
Supramalleolar osteotomy.
would have-
you need
would have
the
used
lengthening of the
distal
fibula.
tibial
That
joint
has been
Yeah.
achieved there.
and
that is more
with the
important.
supramallear osteotomy. I think
No,
that
no.
would have been the best.
But
method.
you need
Supramalleolar
the
osteotomy and synostosis, both.
And synostosis,
Synostosis,
yes.
Yeah.
Yeah. That is the
Synostosis is the
conventional
most
way.
important thing.
Yes, synostosis is compulsory.
Supramalleolar ostomy with a little bit overcorrection into varus and then Langenskiol procedure might have
Yes,
helped.
yes.
Yeah.
You make a
Yeah.
mistake of 5 degrees at least of varus more
Yes.
than valgus. But
Yes.
synostosis, fusion, the fibula was not there at all
Fibula
in the
is
first
there.
place. That's why it has gone into valgus.
Yes, that is the common sequelae of the CPT, sir.
Yeah.
Yeah.
The soft tissue will pull the fibula up.
That is
I
the
have not
reason why it has
seen. I
gone
have
in
not
valgus.
seen a pseudarthrosis of only fibula without
This
tibia
is
being
also
one.
This
This is
a
looks
unique
like
case, excellent case.
osteomyelitis rather than fibula because isolated fibular pseudoarthrosis is
We don't
extremely
see, yeah.
but
Probably it is a post-osteomyelitic sequelae,
Yes.
which
even
has
I
later
thought the
become like
same,
this.
sir. But
Yeah,
when I
whereas
searched the literature,
osteomyelitis is very common. Fibular osteomyelitis. I think it
Do you have
looks
pseudarthrosis
more
fibula
like
only?
yes, sir, the literature mentions it.
How many cases have been reported in the world?
Just now, Campbell doesn't give any incidents, sir. But
Look for it.
he does mention, yeah. In the
But I have now
literature
looked for it
also,
somewhere.
yes, yes.
Your case may be the first case. I have not seen a case like this.
I personally feel it was a osteomyelitis of the fibula.
Yeah, even I feel
Osteomyelitis,
so.
because it's a very
one.
long, thin strip of fibula there
Yes,
from in the whole of distal 1/3. I mean, except the remaining fibula.
So even
In
MRI also
pseudarthrosis, you
shows.
don't get a strip like this, but well, anything can be there.
Yes, yes. Sir.
Yeah, I think we will go to the next speaker.
I think so. Good.
Yeah.
I think,
Nesri,
yeah,
Talia.
Thank you
Well
very much, Dr. Nesri. It
Thank you,
was
sir.
an
Thank
excellent
you.
case.
Ma'am, can
Dr.
we,
Manish,
can we
can we have 15 minutes for each speaker so that
Yeah.
yes, ma'am. Yes,
we'll
ma'am.
stick to
So,
time.
Yeah.
so as ma'am is requesting, the only request we have is for the speakers is to stick to time so that we can have a good discussion and yet finish on
Yes.
time.
Yeah.
So, with your permission, ma'am, I would like to move ahead
Please.
and invite Dr. SHESHGIRI. Sir has a presentation on proximal tibial fractures, use of Ilizarov in the same. It's a difficult case, so Dr. SHESHGIRI, please.
Yes, sir. Thank you very much, sir. Hope you are able to see my screen, sir.
Yes, it is visible.
Yes.
Good evening, everyone. I thank the Asami group, our president, vice president, and secretary for giving me an opportunity. I also want to thank our unit in JSS who supports us to do all these things. So my topic is proximal tibia fractures, short and long segment comminutions, huge skin loss, infection, treated with primary Ilizarov, difficulties turned into opportunities. We want to break the barrier in Ilizarov, demystifying the myths. That means to say that when there is a skin loss, infection, people just don't agree to put Ilizarov as a primary method. They always suggest. So we want to break this myth. So saying that we cannot or apply Ilizarov in wound over the fractures. We cannot do skin grafting with Ilizarov frame in situ. We cannot do flaps with Ilizarov in situ. We cannot do Ilizarov in severe skin loss. External fixation is the form of monoaxial fixator that is better in these cases than Ilizarov. Wounds, skin loss, flap surgeries, then just don't think about this or keep it as a last option. So I wanted to break the myth and go about and do all this in our cases and show, because people should be aware that we can still go ahead and do Ilizarov in all these kind of cases. So what's the opposite misconception is truth and conception. So sanity versus reality. You show them reality, they will be brave enough to do the cases. This is my case one. This is a case of HOFA fracture and a compound fracture type 6 Shattkers in a patient. And this is a CT scan and the 3D reconstruction. So this is what we did. We debrided and we put a plate for HOFA and we put a Ilizarov frame. So this all Ilizarov surgeons can do, and it's not a big thing for them. But what is different in this case is this wound. Look at the wound. The problem is the wound and the skin loss. Even though it looks simple, we go ahead and see. This is after debridement, which we did. And we put a fixator on the day where we debrided. We did not dare to put a monoaxial fixator and struggle later. So this was the debridement and later few weeks. So this was the wound from medial lateral side. We saw the big wounds and still we put a frame and held it. We thought stability is more important in wound healing. So this is after about 10 days. So this was the wound after debridement. Then we put a half ring. We combined 2 rings and made it into half ring so that there is space for people who can do skin grafting or flap. Then after 10 days, then after skin graft, this is the status. So from the image on the left is from the top, and this from the behind X-ray. So these are the procedure dates. So it's about 20 days later, plastic surgery was done. And the take-home message is there is no need to wait for Ilizarov fixation in huge skin loss and defects. It can be used as a primary modality in compound fractures. Even with huge skin loss, we should not get scared to put an Ilizarov on these cases and go for a monolateral fixators. The second case was a case of polytrauma with Shattkar 6 with even more huge skin loss. This was a lady who came to us, and even though the wound looks quite okay, this went on. We did a debridement, and there was a shaft fracture also for this lady. So we covered, and the tibia fracture was very simple. So we did nailing for her for the femur on the same day, and we put her on a frame. And this was the wound. On this wound, we put a frame. So, and we did not hesitate to put, and we thought stability is more important. And with this frame on, we made a walk actually. And then the plastic surgery and other debridement, there was some pus on the initial days. After 1 or 2 debridements from the plastic, and they put the drains and made this less draining, and they go ahead and they put a skin grafting over the frame. This was over the frame. The take-home message is, it's with the frame on, we can do that. And the patient was ambulant all this stage. She was with us for about 6 weeks. And these were all the surgery dates. It's about 2 weeks apart, everything. The first wound debridement, the second wound debridement, and the third with skin grafting. So she got about discharged about 1.5, 6 weeks. So this was the mobilization and rehabilitation. She was very cooperative. She started walking even on the first and the second week with the frame on, with the wound on. With the wound was, there was a lot of soaking, but this did not deter her from walking. And this is the video, and she was very happy. And even now she walks on the frame, and the patient is very happy, and she was very supportive for us. Even here, the take-home message is, even though there is wound, we should not hesitate to use Ilizarov because it gives more stability, helps better healing. Use of half rings or a 5/8 of a ring, monolateral and evo constructs add to the additional cost because we have to remove it after flap, and the whole construct becomes unstable. So we have to make windows of opportunity. So you use a frame in such a way that we can think later, so the plastic surgeon can go ahead and do a flap or do a direct skin graft. We should make some window for them. And the other case was, this was a case of compartment syndrome, Shatker 6. Fasciotomy was done and they're just given to us. So should we operate on these cases, acute compartment syndrome? So this was the case when we did. So we put a frame even on that. They did a fasciotomy both sides, and we did primary grafting. And on the 5th day of the primary graft, they did a fasciotomy and grafting and gave it to us. So then we went ahead and put a frame on this case. And this was a long segment comminution, which is very difficult. So before I used to take long segment comminution without an intramedullary TENS or even a Ilizarov wire. Now we have learned that if you put an Ilizarov wire, it will be more stable. But this patient went on to heal well, and there is some amount of malalignment that we have to accept in very long segment comminutions. So all these cases was to show that even in compound fractures, huge skin loss, there is always a window of opportunity for an Ilizarov to be put. So we want to show these cases because it's all met with success. So if you show them success, the other people will definitely reciprocate all this and do Ilizarov on even bad cases and not do a monolateral fixator because it adds again to more surgeries, additional cost, and lot of instability to the patients. It's better that we put primary Ilizarov. This is the take-home message. Thank you very much, sir. I end my talk.
Thank you, Dr. SHESHGIRI, sir. I'm sure this presentation of yours is going to generate a lot of comments. So may I request Dr. Cherry, sir, to kindly put up his points. Sir, am I audible?
Yes, sir. Yes, sir.
Sir, I have to unmute, sir. Unmute, yeah.
I think you've got a very nice plastic surgeon because my plastic surgeons wouldn't do any plastic procedure with the Ilizarov frame on. Anyway, that depends on the plastic surgeon.
Yeah, he's my classmate, sir.
Okay. Okay. The second case, one thing I don't agree is, can you show the second case? When you put the frame for a fracture or anything, it should span the whole segment. If it is for the tibia, it should span the whole tibia.
Yes, sir.
One ring above and one ring below, it doesn't really help.
Yes, sir.
And second thing is, if you notice that second case, she has got a little bit of equivalence. You've got to take care of that also initially.
Yeah, we got that, sir. And sir, I want to answer your question. Since it's a medical college, we have a lot of scope for experimentation. And actually, we put a 3 ring frame. That's always better, stable ring, a puller-pusher ring, or this one. But we have been experimenting with 2 rings. So 2 rings is also stable. This is another take-home message because I always follow the principle of Ilizarov. We put 3 rings, but my other partner, he likes putting 2 rings. and it really works well. This was also a take home message I wanted to say. Even with 2-ring constructs, it's really stable, and can you see the patient walking? So what we should not be confined, we should always be thinking out of the box and experiment and learn by experimentation. That even I was against putting 2 rings, but I have seen the results. Even the 2-ring constructs are better in, they really do well as equal as 3-ring construct in tibia fractures, sir.
Yeah, because probably because it is the metaphysis, probably you may get away with it, but it's always safer to span the entire.
I understand, sir, but this is more. We have done about 15 cases, 15-20 proximity cases in a 2-ring construct. So it really works. It has never gone bad for us.
Yeah, SHESHGIRI.
Yes, sir.
Good work.
Yes.
Thank you. An eye opener. I have 3 papers published on tibial condyle fractures in the last 30 years,
Yes,
done by Ilizarov treatment. Very rarely I have put 2 rings only.
yes, sir.
It is so unstable unless you put drop wires and half pins up and down to cover up a small segment. They never hold that well. I know after a month or so, they become more comfortable, but then pain is more till that time. This is the reason. To see that they do not have pain. Now, what happened to these 3 patients or maybe your other patients is so much wounds are there, they accept the pain. They blame it to the wounds.
Yes,
But
sir.
we should not give pain because of the fixator.
Yes, sir.
So stability is very important when you want to put the fixator. Yes, experimentation and all that, because we are in college and all that we are there. That's how I also picked up Ilizarov and did Ilizarov because we were in a college. Okay, but we are not experimenting. Little bit here and there we are trying to improvise on whatever we do. I think we better put our terms that way, that we are in a medical college, so we try to improve and get a chance like that compared to the private practitioners. This is an excellent eye-opener that all major wounds where Ilizarov you should not put, you should put only AO is advocated, is only a myth now. Because we put Ilizarov as emergency also when I was in Ramaya Medical College. Yeah, this is for all your information. I have retired from Ramaya from first and I have joined Saptagiri Medical College.
SHESHGIRI, it's a very nice presentation.
Excellent.
I think most people will not be ready to accept it.
Yes.
But I accept that. The only issue is when you show the 2 rings, as Harshad said, the youngsters are going to do it.
They will fail. It will be difficult.
It's only a skill to stabilize with 2 rings. So to learn that skill, you must have done so many 3-ring concept.
Yes, sir.
Here in this particular case, if you had a ring at the lower end, you can have a full ring. You can just keep a half ring, make it into 1 unit. The whole area will be completely free for grafting.
Yes, sir. So, but
that area can be completely left free.
Yes, sir. But no, sir. I'm just using this as a platform. The first case which we put 3 rings.
Yeah.
But the other thing why I wanted to show was we were getting almost the same results. So I just wanted to put
that is because you are putting adequate pins.
Yes, sir. If you put even 2 ring was.
Yeah, you will get results may not be. You will get the same result because you are putting adequate pins.
Yes, sir.
So, but the problem is youngsters may not put that much.
Yes, sir.
And they may land up in trouble, and they will always quote, SHESHGIRI did only 2 rings. Then where should I put it?
No, sir. That's not the message what I want to convey.
Anyway, nice presentation.
Thank you.
A lot would depend on the fracture stability.
Yes,
so many things.
If the fracture is an entity stable one, it may still be possible to get away with 2 rings.
Yes, sir.
If there's a lot of combination, then 2 rings will definitely fall short.
Yes, sir.
Ma'am, would you like to comment on the thing?
No, I think we will go ahead to the next case.
Yes, sir.
SHESHGIRI, how you have done a grafting on that upper neurosis?
Sir, we give it to a plastic surgeon, sir. He's my classmate and he's my friend. And
so the upper neurosis has been taken off.
Yeah, I expected this question. I expected this question, sir. But I don't know, miracles do happen for people who are really deserving. That will be my answer.
They might have excised it and
I did not do the grafting, sir.
And Shesha, I think superficial wounds for split thickness skin grafting, you should do it. Don't refer to your plastic surgeon.
No.
Have you seen me doing it? You were there in Ramaya for so many years before.
No, sir, we do. For the
No,
first and the third case, I think we did. But the second one, the plastic surgery, because there is a department we have to support. So it was done by
We are
them.
giving
all right,
training for
I'm
them.
just out of this
You are
one.
giving training for them.
No, no.
Good luck. Good cases.
Thank you, sir. Thank you.
Okay.
Great.
So, sir, so if you could please unshare your screen. Ma'am, can we move ahead with the next
Yes,
presenter?
please.
So, may I invite Dr. KARAN KUKREJA? He'll be speaking on cosmetic limb lengthening. Dr. KARAN, please.
Good afternoon. Good evening, everybody. I'll just start sharing the screen once. So I hope it's visible to everybody.
Yeah.
It
So
is
this
visible.
topic is going to be, it's known to be a controversial topic. There's been a lot of discussions. In between, there's a lot of media reports on it in Hyderabad. So I'll just present one case about a bilateral cosmetic limb lengthening. And the difference from the typical one is because it is done with by lengthening over nail. So that made the process a little bit simpler and saved a lot of treatment time. So let's go to the details. This is a 28-year-old lady who was 5 feet 1 inch tall. She was healthy, physically fit, and quite a thin-built lady. And she wanted to have a cosmetic limb lengthening done. And the main reason was that she had been teased and harassed about from childhood. And she was young, shortest by far, almost 6 to 8 inches shorter than her close relatives. And she was very emotionally attached to gaining the length. In addition to psychiatric evaluation and counseling, she was also referred to 2-3 senior consultants within the department, the hospital owner also, to get their approval before considering surgery, because she was very insistent on surgery and I was a little reluctant to do it. And only when everybody agreed, including the hospital MD, did we actually go ahead for the procedure. So the plan was a bilateral tibial lengthening over nail, followed by bilateral femoral lengthening over nail, 3 inches each, that is 7.5 centimeters each. That was the plan. And you don't want to do more than that, because that would affect the body proportion. It would make the limbs too long, because she was a person with a normal body stature. So this is a preoperative X-ray, which is normal. Okay, so the surgical steps, I'll just focus a little bit on the surgical steps. The step 1 would be a fibular osteotomy, which we did in the middle and lower third junction. And the step 2 was for corticotomy preparation. But we didn't complete the corticotomy at the beginning, but just prepared it to make the seconds, to make it easier later on. So we mark the level of corticotomy to ensure that it is as close to the metaphysis as possible, but also have adequate space for 2 locking bolts of the nail. It has had to be slightly more distal than what we would like to do normally. And then the drill holes of the corticotomy were made with the drill bit. Then the next step was to insert a tibial nail with a standard technique. And she was a very thin-built lady with small bones. An 8 mm diameter nail was only used, which is locked proximally with 2 bolts. And the nail was not locked distally. That's a very key part of the procedure. And nail length was selected to allow some space distally for fixation with the Ilizarov frame. And the next step was to assemble and fix the Ilizarov frame. We used 3 rings. And the middle one is a ghost or free ring with no fixation to the bolt, to the bone. It's only used to make the frame a little bit more stable. Since the nail also contributes to some extent to the stability, the number of wires required and the pins were required were a little bit lesser than what we normally use for limb lengthening. And the wires and pins were used all in the proximal and the distal end of the tibia, where the bone is broader and there's space available for a frame. So in this patient, I had used 1 wire and 2 shanks pins proximally. Actually, I would like to have 2 wires and 2 pins, but the second wire was not able to get it in the correct location. It was going quite posteromedially into the pes sensoriness. So I then accepted that, manage without that 1 wire, with only 3 fixation proximally. Distally, I got 3 wires and 1 shank pin. The fibula has to be fixed to tibia both proximally and distally. This is important irrespective of what method of lengthening is done. We have to lengthen the tibia. We're not just lengthening the tibia, we have to lengthen the entire limb. So the fibula also has to lengthen in symmetry with the tibia, which has to be fixed both proximally and distally. And the next step was the procedure was to complete the osteotomy, the corticotomy with an osteotome. It was slightly more difficult with the nail in situ because nail itself gave a mechanical block to easy completion of the corticotomy. And then the entire process repeat for the opposite side. So this is the immediate post of X-ray. You can see the corticotomy site. A bit of shattering also was there. The free ring, the fibular osteotomy, and a bit of space available distal to the nail where the fixation of the frame was done. And the post-operative technique was almost similar to the standard technique for limb lengthening. Somehow I prefer to start lengthening a little slow rate at about half millimeter per day initially, that is 1/6 of a nut, 3 times a day, and then increase to 1 millimeter per day when the regenerate is good. And the target length was achieved in 3 months. So this is a few months later. We don't see much regenerate yet. Once the length is achieved, even if we don't see much regenerate, we can go to the next surgery where we do the distal locking of the nail using 2 bolts. It was slightly difficult because of interference with the frame, but it was possible. And after fixation with the bolts, only then we had to remove the frame. Otherwise, you can lose a bit of length that has been achieved. 1 year later, this is what is the situation. The regenerate is consolidated fully. You can see the nail is not ending distal to in the distal part of the tibia, it is ending much more proximally. There is a small gap in the regenerate anteriorly on the left side, but with the nail in situ, we're not too worried about that. This is a scanogram for the same. Then the next step was bilateral femoral lengthening, which was done on the fracture table in supine position. The steps of surgery is slightly similar to the previous one, where we first prepared the corticotomy, and the level marking and drill holes made. Then the nail was inserted. The 9 mm nail was used. In this situation, I fixed with the LRS. The patient was insisted on an LRS fixation rather than the Ilizarov for the femur. We completed the corticotomy and then repeated the process on the opposite side. In this situation, there were a few difficulties encountered. The bone was thin, and even a 9 mm nail had a very tight fit, even after reaming the nail, reaming the bone. There was a slight bending of the nail at the proximal locking hole, which of course didn't contribute to any problem post-operatively. This tight fit of the nail also made completing the corticotomy difficult because I had to rotate the bone, twisted to break the posterior cortex. That was more difficult to achieve. Other issue that was the longest LRS frame did not have enough length to allow for 7.5 centimeters lengthening. So we had to have an attachment, an extension attachment was used. And the only one that was fitting perfectly was the ball and socket clamp one. And that allowed us to get 2 pins proximally, 2 pins distally in the femur. And this is a post-op X-ray where you can see the nail plus the LRS pins. The distal pins are posterior to the nail, and so are the proximal pins. The post-operative treatment rehab is similar to the previous one. In this situation, our target was 3 inches, that is 7.5 centimeters, but she was quite happy with 2 inches itself. So we stopped at 2 inches of lengthening instead of 3. And in this situation, again, the difficulty that I encountered was the snug fit of the nail resulted in extreme resistance to the lengthening. So in the initial process of lengthening, the frame was bending. The LRS frame was bending. The pins were bending. The frame was bending, but the bone did not move. Instead of bone and the frame moving together, the bone moved much later than the frame movement. And this also caused a bit of varus. But a few weeks later, the bone started moving as it should move. Okay, and there was a bit of varus here. Then the same procedure as for the tibia, the distal locking of nail is done before the removal of the frame. And in this situation, the frame was correctly blocking the distal locking. So I had to use a thick K-wire inserted medially to hold the length. Then the frame was removed, and then we had to do the standard locking with, from the lateral side, the locking bolts from laterally. And 2 years after the frame was removed, she was 5 feet 6 inches height, which is what she wanted. She was very happy with the outcome, full restoration of movements and full function. These are the final X-rays. In the femur, you can see good consolidation of the regenerate, a minimal varus. The tibia, good consolidation of regenerate, except the anterior regenerate on the left side is also good. And these are the cosmetic clinical pictures, good range of knee and ankle movement. And these are photos of the patient before the first surgery, after tibial lengthening, and after the femoral lengthening also. There is a significant gain of the height. Unfortunately, the first photo did not have anything to compare with. We cannot really have an accurate assessment of what height was there, because when the first photo was taken, there was a proper scale and I could measure the length. I didn't anticipate that I would have to have some photos to compare like this. So to conclude, cosmetic limb lengthening is a very controversial topic. a lot of legal and moral questions are raised. In some situations like achondroplasia or hypochondroplasia, it is definitely acceptable, but in others, it's a little gray zone. So careful patient selection is the key. In this situation, the advantage of lengthening a nail was a shorter time on the frame, just a few months each. The nail will have a normal function even if the region is patchy. The frame construct is easier, but the difficulties that we faced, one is that the lengthening is along the anatomical axis of the femur, which is not a very major issue for short lengthening. You cannot correct deformities. The surgery was slightly more difficult. That is, insertion of pins, especially in the femur. Completing the corticotomy on the femur was difficult because the nail prevented the rotation of the bone. The distraction also was more difficult in the femur. And of course, there's a minor problem of increased cost and surgical time, but that's very minor. So with this, I would like to ask any questions. Thank you, and any questions?
Thank you. Thank you very much, Dr. Karan. May I now request Dr. Harshad Shah, sir, to kindly.
Well, Karan,
yes,
you got guts here. Well done. Huh? Very proud of you. All right, only one question. How much did it cost the patient?
The cost for the patient.
The cost is very high.
Yes,
is it possible to disclose, or later you will tell me? No problem.
This was done in HOSMED, where each of the procedures were the tibial lengthening part was charged 2.5 lakhs for both the Ilizarov and the tibia nailing.
That's very cheap.
Yes. Then the
very less.
The second surgery, distal locking, was about 50,000 they charged. Then the femoral lengthening also was about 2.5 or 3 lakhs. And the distal locking for femur also was about 50,000.
Okay, I think that is very, very less what you have charged.
I didn't have any say with the money part of it.
Doing something like this, you require a lot of experience and a lot of problems. A little bit problem here and there onto the patient with restricted hip, knee movements, ankle movements, or any complications. They are going to court and sue you for more than 10 crore rupees, even the poorest of persons. And the judge will treat it sympathetically towards the patient, not us. You understand?
Yes.
So be very, very careful about that and don't do it for such less charges. I don't think you should do it less than 10-15 lakh rupees. Drawer Peli charges more than 1.5 crores is what I have heard. I do not know. Lengthening our nail in Bombay costs more than 75 lakhs is what I have heard. I don't know how much Dr. Agarwal's charges, because their charges are the least in India. They will do every day 5 cases. I'm not talking about cosmetic, Ilizarov surgeries only. Sir, no, you are muted, sir. Dr. Agarwal, you are muted.
Dr. KUKREJA, you can stop sharing your screen.
KUKREJA, congratulations. You got excellent results for everything. Only one thing I observed was the nail is probably an inch shorter, longer, proximally.
Yes,
proximal to the trochanter, outside the trochanter. It should go deep down up to the trochanter. Otherwise, your hip abduction, hip movements will get restricted. And it will be painful. You understand?
Yes.
So plan to remove it 2 years down the line. Plan to remove the nails.
Yes, that is planned for. But if they put this particular nail design had the screws in a location where if you push the nail in fully, the corticotomy had to be almost at the isthmus or mid-sharp. That's why
it doesn't matter.
Slightly proximal.
What does it matter? No. That is how it is. It doesn't matter. And you have nails where you can put screws proximally into the hip joint.
Yes.
Okay. So you got enough areas in the subtroch area. What about soft tissue releases? Have you done any soft tissue releases for this? Expecting hip dislocations, expecting varus. Varus was expected. So you need to release.
No soft tissue procedure done.
You need to release the vastus, lateralis.
None of those were done.
Hamstrings.
No, nothing. No soft tissue release.
No, yeah,
so much of lengthening in an adult. You have to be careful. The other day I saw one patient with bilateral hip joint dislocations who tried femoral lengthening. They just came and talked and ran away and went off. So I don't want to name who has done why it is, but you should look for all those things. Be very, very careful. Be aware of that and keep taking X-rays. Everybody must do that. And cosmetic limb lengthening, everybody please remember, the patient is totally normal before you do it. Understand? And 5.1 inches is not a dwarf. Dwarfism, yes, it's a deformity, it's a problem you can treat. Achondroplasia, yes, it's a deformity, it's a problem you can treat. But when it comes to a normal person, if they are quite short, you, okay, do it. Remember that the results that you have to give is totally normal. Otherwise, don't ever venture to do. They are doing, a lot of people in India and across the world are doing it. I'm not saying no, one day it is going to become standardized, but be very careful about treating them.
It's a gray zone.
Lot of mistakes occur not because of us, because the patients do not come. They have a lot of problems and all that. You understand? So good work, Karan. Congratulations.
Thank you.
Okay,
But
Dr.
Karan,
Bijlani, you have
it's a
any
good
comments?
idea, but it's a very dangerous surgery. I tell you, lot of competition took place. In United States, they have a special nails that cost 10 lakh per nail. So it comes automatically, but you have done an excellent job. Only there is some virus is there at the femur. Virus is there. But if even 2-3 degree of virus is there, there will be problem in the walking. I think so.
Yes.
Karan, Karan, did you want a couple of questions? Did you make the corticotomy drill holes before putting the nail before reaming? That's a good thing, because if you ream without that, you can have a air embolism. I mean, that fat can, the reamings can go into the veins. The second thing is, I mean, you've done a good procedure, but always, like Harshad said, I would agree with him. You're doing it on a normal patient.
Yes.
So complications are not at all tolerated, both by the patient and the court. That is, keep that in mind. And thirdly, always remember, lengthening of a nail in the series of Dorpele and Hessenberg, there is a 25% chance of deep infection.
Okay.
So that is also, keep that in mind. And a deep infection can be a disaster when you're lengthening it over nail. But otherwise, it's a good procedure, but always be a little careful when you're doing these procedures.
Yes.
I have few comments and few questions. First of all, Dr. KUKREJA, can you hear me?
Yes, I can hear you.
Yes.
Yeah. So, Dr. KUKREJA, actually, you have done really a good job. It's an excellently worked out case. What was the duration of treatment, the entire duration?
So the tibial part was about 2.5 months, 3 months for the frame fixation. Following which she was about 1 month after the distal locking, she was walking comfortably. And about 1.5 years after the tibial tibial procedure was fully completed, then she underwent the femoral side.
Okay.
And femoral also took about 3 months.
Okay, so I totally agree with you. It's a gray zone, undoubtedly. So everybody has pointed out, and I totally agree with it. And especially for youngsters, I have to give you the message of not venturing into cosmetic lengthening unless and until you do at least 100 lengthenings for other indications. Cosmetic lengthening is a surgery only in the hands of experts who can deal and prevent complications, which can be really hazardous. So it's really a gray zone. Okay, about few questions. In tibial lengthening, before removing fixator, in lengthening over nail and even in lengthening over plate, you have to put a screw from fibula to tibia, a syndesmotic screw, because the fibula degenerate is not good. So the fibula can migrate up. So to prevent that, before removing fixator, you have to do that. And there was one question about mechanical axis being shifted into valgus in case of femoral lengthening, which is true. That happens with lengthening over nail in femur. The knee goes in valgus actually. And in your case also, there is mild valgus. But it's not a big concern in short lengthenings. Good thing is that you have done short lengthenings in both tibia and femur instead of one long lengthening.
Yes.
I think that is a good idea. All in all, it's a very well done case.
Thank you.
May we move ahead, ma'am?
Karan, I congratulate you. It was very good.
Yes, please.
But you must have arranged for an 8 size nail in the femur.
8 size femur is not available.
It's available.
Okay.
If you want, it's there.
Is it? Okay. Because the nails are available.
I have used the humerus nail for bilateral femur lengthening.
Yes.
You get all those sizes. But that girl probably was big. The
How was the
humeral
pain?
length you may not
How was
get.
the pain during the lengthening? What about the pain? Usually they cry of the pain.
She was very tolerant. She was very well read up. She had read up a lot about the procedure. She knew what all had to be done.
Yeah.
And she was very compliant with the entire process. And she had almost researched and made her mentally ready for almost 4 or 5 years before she actually underwent the procedure. And that way she was a good patient for all of this. And the thing is that the pain was not much. She never really complained. And one of the other things which I very comfortable with is lengthen at a slower pace at 0.5 millimeter per day, and only increase it later on if everything is okay. That may also be one of the reasons why the pain was lesser. The only time she had some pain was during the initial part of femoral lengthening where the frame was bending, but the bone was not moving. So the frame had achieved almost 2 centimeters length, but the bone was still almost stuck together itself. The corticotomy was not moving. I had a doubt about incomplete corticotomy may have occurred. But fortunately, a few days later, after continued lengthening, the bone started moving, and then the pain reduced. Otherwise, she was quite painful.
During that 3 weeks, your pulse rate must have been very high.
Yes. Yes.
Yeah, like Dr. Ruta has told, unless you have tremendous experience, please don't operate on normal limbs.
And Harshad,
yeah, Karan is senior. He looks very young, but he's quite senior now. Don't worry.
Russian were telling, are you eating fish? If you are not eating fish, go next year. Harshad was there.
Yeah, so we both had gone.
You have to take the fish, very necessary for during the lengthening period.
Yes.
So I always give, we have a shop in our hospital of the fish. Every cases who are doing lengthening, they are purchasing that.
Yeah, vegetarians, it's contraindicated lengthening. Do you know that, Karan? Was she vegetarian or non-vegetarian?
No, actually, I don't know. I didn't ask her that.
Don't know. Oh my goodness. But you go to Russia, they'll refuse and send you back. Dr. Agarwal just now told you, no. If you are vegetarian, 1 year you must eat fish and come. And they will give you there. You need to stay there for 6 months. Fish and other non-vegetarian food. Otherwise, they won't.
You should never do in vegetarian lengthening other things. It will be a disaster, I tell you.
Okay.
Be careful.
I think
disasters can occur.
Okay, ma'am. So, thank you, everyone.
How about fracture healing? Fracture heals less in vegetarian?
Yes, I tell you. The patients to whom I have started the fish taking, they are having the very good union rate, I tell you. A lot of fish shops are in my in front of my hospital. You know?
Must be your own shops.
No. Yeah, maybe Dr. Agarwal shops only.
Yeah.
So now may I invite
Dr.
Congrats.
Dr. Aradhana to kindly present her cases of distraction osteogenesis in finger contracture and case of patella non-union.
Yeah, I will share my screen, sir. Sir, is it visible, sir?
It is visible. You are audible.
Yeah.
Yeah. Go ahead.
Yes, ma'am. Yeah. Thank you so much, ma'am, and Vice President, sir, and Secretary, sir, and all the panelists who have spent their time on this holiday. I will move to my first case, where I have used principle of distraction osteogenesis in treating a case of finger contracture as well as a case of patella non-union. The first case is finger contracture. This lady, 28-year-old female, housemaker and laborer as well by occupation. She came with deformity of index finger since 4 years. She had difficulty in doing her day-to-day activities, especially cooking. And the finger was coming in the way during any other procedure as well. She had history of abscess in the index finger 4 years back, which was drained in a local government hospital, probably by a general surgeon most often, where they treat the abscess, but they forget to splint the finger. This was the finger, and the patient had fixed flexion deformity at the PIP joint of around 90 degrees and DIP joint of 80 degrees. Sensations were intact and pinprick bleed was normal. The patient was initially sent to plastic surgeon. Then they advised her surgery in one single sitting, but they did not give any they told that the patient might have gangrene and she might lose the finger as well. Then she was referred to us also for another opinion, where I explained to her regarding gradual distraction process, and even I gave her the option that during the procedure, if the finger might undergo gangrene and she might lose the finger as well. So she agreed for a gradual distraction process, and under wrist block, 2 K wires were passed. 1 K wire was at the junction of metadiaphysis of the proximal phalanx. Another was at the base of the distal phalanx, and 2 distractors were connected on either side for better controlled distraction on either sides. This was the frame after the procedure. So I started with half thread per day initially, so that the patient is well versed with the distraction, and later on continued for 1 thread per day. Patient was very well cooperating for the distraction, and this was the picture during the distraction. She came for follow-up, and it took around 45 days for the deformity to get corrected. I took her to the OT and removed the distractor, and this was the final correction which I achieved. There was no necrosis, there was no sensation loss. The finger pinprick bleed was absolutely normal. This is the comparison of pre-op and post-op. Here we can see the patient finger deformity has been achieved. Correction has been achieved in lateral and anterior-posterior view. The patient is very happy, though the flexion is not possible, but the patient is very happy with the cosmesis as well as her functional demands have improved. My second case is a case of patella non-union. He was a 40-year-old male patient, laborer by occupation. He had injury to the left knee 4 months back. Patient had difficulty in walking, climbing stairs, getting up from sitting position. And on examination, patient had a gap. Clinically, I could measure the gap of 7 centimeter in the flexion. He had a gap at the patella fracture. And in extension, he had a gap of 4.5 centimeter. This was the X-ray. Patient had hold neglected patella fracture with gap. When I went through the literature, there were various literature supporting for VY plasty as well as gradual opposition by a compression device, and later on internal or to continue the fixator. For my plan was gradual opposition by the compression device and go ahead with internal or external fixator. This was the OT procedure. I took him up under spinal anesthesia, and 2 K wires were passed in the proximal fragment and 2 K wires in the distal fragment. And I connected on either side with a compression device this way. This is how it was connected. And I asked the patient to start range of knee movement as well as start compressing it gradually on either side. I never allowed the patient to be bedridden. I asked him to do all his activities of daily living. I discharged him and I asked him to come back when he could achieve complete compression at the fracture site as well as range of knee movement at least up to 90 degrees. So once he achieved this, I took him up for the OT. This is the final stage when he has achieved enough of compression and wires start bending after that. This was another patient. I did this just for a reference. where this kind of screw can be seen and wire start bending. This is also another time where we can stop compressing and take him up for surgery. So during stage 2, I explained to the patient, but patient told that he had some function and he couldn't take the external fixator anymore. And I went ahead with internal fixation. I went ahead with tension band wiring, and I put a tension relieving SS wire this way to safeguard my tension band wiring procedure. And this is after the suture removal. We can see there is absolutely no extension lag, which usually we expect in VY plasty when there is such case of patella non-union, and there is absolutely no infection, no necrosis of the skin. The wound has healed very well. And range of knee movement, we can see the flexion is going up to almost 60 to 70 degrees. This is the advantage of having a fixator initially before taking up for the OT. This is at 1 year follow-up. The fracture site has healed well. The only problem is hardware prominence, which is not allowing the patient to flex the knee completely, but there is no extension lag. This was the video which we got at 1 year follow-up. Absolutely no extension lag and very good power of the quadriceps. Thank you so much. Sorry, this is another case. Yeah, any inputs, ma'am?
You're muted, Dr. Harshad.
It's an excellent performance.
Thank you,
So it's an excellent performance. Actually, what I felt that whenever you do the distraction over the finger, even
Yes, sir.
you do not need the skin grafting. If your distraction, yeah, that is the main
Yes.
thing. Histogenesis takes place. I
Yes,
found
sir.
that initially I was thinking to do the skin grafting, but later on our rate is 0.5 millimeter or something else. So it takes the histogenesis, and
Yes, sir.
you don't need the skin grafting. Second, your
Yes,
case
sir.
was very excellent. I never thought, first time I'm seeing that case. So
Yes.
I was thinking that those cases of the old fracture which goes for the upgrade of thing of the patella, they can come down, and
Yes, sir.
you don't need the cordoplasty.
Yes, sir.
So second thing, I was thinking the tendo Achilles, which goes to upward, I can put the something like that, and I can
Yes.
bring that, so it will be easy for the you maybe you cannot you save by the tendo Achilles lengthening VY-plasty. That's a good
Right,
idea.
sir.
Good
Yeah.
idea.
Thank you, sir. Thank you,
Yeah,
sir.
Aradhana, I must say both the cases were excellent. Very,
Thank
very
you,
good,
ma'am.
very well worked out,
Thank
undoubtedly.
you, ma'am. Yes, ma'am.
About finger contracture,
Yes.
what about recurrence? How did you warn about recurrence, or what about range of movement?
Range of movement was not there, ma'am. The ROM was only at the metacarpophalangeal joint. Her flexion, active flexion was not there at all. I explained even that to the patient, but she was like, okay, I can carry out my activities, and the cosmetically it is very much better. I'm really happy. Rather than amputation, I am really happy with the finger. And yes, ma'am.
But these deformities can recur. You know, so.
At 6 months, last I could have only 6 months follow up, ma'am. I'm because of the COVID, I have lost the follow up of the patient. She has gone back to her native. Once she comes back, probably I can really get the photos and present it again if she can come back. Yes.
Actually,
ma'am.
these patients, these the night support is very, very important,
Yes,
because there
sir.
is a fibrogenesis,
Yes, sir.
not osteogenesis. The fibers, it is healed by the fibroblast. So
Yes,
there are
sir.
more chances of the
Recurrence.
of the deformity, because whole thing is a fibroblast. So
Right,
that
sir.
is most, you have to give the support in the night also.
Right,
It
sir.
was a very nice case.
Thank you, sir.
Wonderfully done.
Thank you, sir.
Was there a flexor tendon acting in that flexor contracture patient?
Sir, only at the MCP, but that can be due to lumbricals also.
Lumbricals also,
Can't say, sir.
If the flexors are not there, then
yes,
there is
sir.
no chance of flexion contracture again.
Right, sir. Right, sir. Understood.
If the flexors are there, then the chances are high. Have you checked the grip strength before and after?
It was same, sir. That finger did not add to any grip strength. That I have checked. The finger was not having active flexion at all, even after the correction.
So if the flexor is intact, then your
Yes,
extension
sir.
will limit the, it will reduce the grip strength.
Yes, sir.
The flexors are not there, then the grip strength is not going to change because all the fingers are having single flexors.
Yes, sir.
So once the flexors have gone, then there is no problem.
It's actually
common, wonderfully well.
Common
Thank you,
problem
sir.
of these
Thank you, sir.
patients are that we don't have the flexion. So that is a common patient. But I say, okay, it's good you have your finger has been extra corrected. You may need some very minimum flexion they have. Otherwise, they don't have, but they are very much satisfied by that.
Yes, sir.
Both these cases are very well done. I should
Thank
really
you, sir.
congratulate you.
Yeah,
for that.
Aradhana. Excellent.
Thank
it
you.
was.
Thank you,
Basically,
sir.
this was for correcting the deformity, which was very
Yes, sir.
bad, which
Yes,
was
sir.
not functional. So you corrected
Yes,
it.
sir.
I
Yeah.
generally have done many of these cases, but I put two pins, not a single pin.
Right, sir.
It gives me more
Right, sir.
support. Plus,
Okay.
from the distal end of my finger, I
Huh.
pass one pin like that and make
Okay.
a U frame to hold this distal finger. So same
Okay.
thing.
I think there is network issues, ma'am.
Yes.
Terry, you can go ahead with your comment.
No soft tissue surgeries. It came well, and she could hold a glass. It has been published long back. I don't know where it is, but then I can send it to you. It's beautiful.
Yes, sir.
Her case is
Yes,
also
sir.
nice. Particularly
Yeah.
when plastic surgeon said you may have to amputate it. You
Yeah.
understand? Excellent.
Yeah.
The
Even
patella
for her,
also-
they had told, sir. Yeah. Yes, sir.
The patella is very good.
Thank you, sir.
Patella is fantastic.
Sir,
Thank
Dr.
you,
Agarwal,
ma'am.
you're
Thank you,
muted.
ma'am.
You're talking, you're muted.
Actually,
You're not able to hear him.
when we keep the two wires, so it becomes difficult to rotate the things.
Ah,
Yes,
That is
sir.
also one wire is.
No. I won't have put in the middle finger. Proximal and distal. Proximal and distal. The distal hold is better with one wire going through the vertically, like that, going vertically through the distal phalanx, and one wire going transversely like this. Then this is connected with a U frame.
Okay.
This frame
Understood, sir.
will get to the
Yes.
distract very easily. And
Yes,
it
sir.
controls the distal phalanx very well. And in this case, it has not only gone into flexion. In Aradhana's case, it has
Yes,
not
sir.
only gone into flexion, it has subluxated and dislocated anteriorly. So
Yes,
you
sir.
can
Yes,
see
sir.
the distal phalanx has come down so much.
Yes, sir.
But then with a single wire, you could do it. It's magic. Wonderful. Like Dr. Agarwal was saying, it would have rotated. The whole thing would have rotated on that wire and you got your result.
Yeah.
Yes, sir.
Even in the flexion of the knee contractures,
Correct. Knee
we use
contracture.
single wires. Otherwise,
Yes,
if you
sir.
put the two wires, it's very difficult to correct the flexion deformity.
Yes, sir.
Russians were telling me you keep one wire.
Yes, sir.
So it's an excellent case.
Thank you, sir. Thank you, sir.
Good.
Thank you,
All right.
Dr.
Any
Aradhana.
questions?
Very well done.
Thank you, sir.
Ma'am, I think we are through with the presenters.
Yeah. We'll
And
wind up.
Dr. Jain is not there, but on your behalf as well as Dr. Jain for registration for the next year March at Indore. So sir should have been here, but somehow I am not sure why. So ma'am, would you like to give your concluding remarks, ma'am?
Yeah, I just want to thank everyone for excellent cases, really good cases, good learning message from all the cases. Thank you very much for joining in. And please do attend tomorrow's meeting. And please come for the conference, AsamiCon 2023 on 3rd, 4th and 5th March to Indore. So please log on to asamicon2023.in and you will get all the details. Thank you all and good night.
Thank you, ma'am.
Thank you.
Assam India must thank ARADHANA, Karnataka.
Yeah, thank you so much, sir. Thank you for giving me the opportunity. Yes,
ARADHANA has done the excellent job.
Yes,
thank you, sir. Thank you so
People
much,
were
sir.
telling me that
all of them have
to
grown.
your
So
efforts,
Karnataka,
it was possible to conduct this course.
Yeah, thank you, sir. Thank you so much.
Okay.
Okay.
Goodbye.
next month, whose is it? Master class?
Goodbye. Goodbye, Aradhana. Goodbye, Ruta.
Goodbye, sir.
Bye.
Goodbye, sir.
Harshad,
Thanks for joining in.
It's still
Manish,
recording.
looking forward to see you back
No
again.
personal questions.
Yes, sir.
Yeah, we'll meet in Assam,
Very
India, of course.
Yes, sir. Yes,
How
sir.
was it in IOACon? Who had gone to IOACon?
I've gone.
Sir? So Ilizarov workshop course?
Yeah, it was done very nicely.
It was done very nicely.
Yeah,
How many
yeah.
candidates attended?
Because it started at 8:30.
Huh.
So initially in the morning session, only we four were there, but gradually the people have come there.
Ah.
But initially we were 6, 7, 8 persons. Because it started at 8:30. But gradually 20, 30 people has come.
Then today's meeting, we can make out how many people had come, logged in.
Sir, 13 of us had logged in on this through this ID, but there must have been others. We'll have to find out, sir, because for
No
the
questions
audience there
from
was
them?
another link, sir. There was a question which Dr. Amar
audience
Soni had that
that
Madam
will
has
have-
already clarified, sir, about the mechanical axis deviation
Yeah,
in
about the
femoral.
mechanical access. Yes. So I think I will take your leave. Thank you, everyone, and good night.
Thank
Okay,
you.
bye.
Thank you, ma'am.
Good
Thank
night.
you, ma'am. Good night,
Bye-bye.
ma'am. Good
Thank
night.
you. Good night.
Good night, everybody.
Good.
Thank you,
Aradhana.
Dr.
Good
Good night, sir. Thank you,
Nicely.
sir.
Bye.
Thank
you,
you so
everybody.
much.
Karan,
Good
well
night.
done.
Thank you, sir.
Shesha, well
Yes,
done.
sir.
All four.
Bye, sir. Bye,
Bye,
sir.
bye.
Thank
Thank
you,
you. Good
sir.
night.
Thank you so
Chale?
much. Yeah. Yes, sir.
Okay.
Thank you, sir.
Okay, for some screenshots, right? Bye.
Yes, sir.